Thank you for joining us in what is our first of hopefully a series of seminars, a mixture of online and in person as we go through 2022. I'm delighted to welcome our first speaker of the new seminar series, Dr. Emily Murray from our own department. We'll be talking about her project, Health of Older People in Places. Welcome, Emily.
Good afternoon. I'm delighted to talk to everyone about, my research project, the health of older people in places, or what we call HOPE. And it's a Health Foundation funded project with Jenny Head, Nicola Shelton, and Paul Norman. But what I should really say is that this isn't just my research project. This is definitely a team effort with Paul and Jenny and Nicola. And this project is a part of a larger project that the Health Foundation has funded, looking at health as an asset for economic and social improvement for all. And there's a little blurb here about that. But this research project is focusing specifically on whether the proportion of older individuals in a place, whether their good health is associated with better labour market related social and economic outcomes in those places. So that's just a little summary. And so just to give a little bit of background, something that probably everyone here is aware of is that we live in an aging population. And in response to this, what was recently increasing life expectancy and population aging, lots of governments, including the UK, are trying to increase retirement ages and state pension ages and encourage people to remain in work up to and beyond the state pension age. And just to give you an idea of what that looks like for the UK, we have the UK state pension age legislation that's happened quite recently. So they took the state pension ages for women, which used to be 60, and have brought them up to be the same as men at 65. And this is for both men and women has been going up to age 66. You can see in the figure here what has been happening and will supposed to happen for state pension ages for women. And then it will increase to age 67 for both by 2026. And that's the way that it stands now for legislation. And one argument for why this is okay to raise the state pension age is that there is great variation across countries in the ages at which the proportion of older workers who are still in paid work at older ages. So I think this figure is a little bit hard to see, but you can see across the OECD countries, they're saying the blue dots are showing you the proportion of people aged 60 to 64 who are still in paid work in that age group. So all the way at the top in Iceland, I think it's saying about 82% of 60 to 64-year-olds in Iceland were in paid work in 2017, versus all the way at the bottom, which is Luxembourg, only 12% of that older worker age group is in paid work. And if we look at where the UK was in 2017, I think it's a bit more than half of 60 to 64-year-olds still in paid work. So you could argue that there is some potential room for moving up the state pension age based on that. And this is, of course, by gender. So there tend to be more men in paid work in these age groups as well. But one thing to notice in this figure is look at the green dots. So this is just going up a 5-year age group to 65 to 69-year-olds. So in the UK, it goes from more than 50% of 60 to 64-year-olds in paid work, all the way down to 20% of 65 to 69-year-olds. So people are dropping out quite quickly of the labor force in this age group. So I'm going to go forward. And if you look at kind of long-term trends at the ages at which people are leaving the labour market in the UK, this has been going up. So I think about since 2000, the ages at which people are leaving the labour market, the average was now about 65 for men in 2021 and 64 for women. But I think there's three things I want you to notice about this figure. The first is that the average age of exiting the labour market for men is 65. So half of men have left the labour market before the state pension age was. That the average for women is below the state pension age. And that there's been a sharp downward trend in 2021 for both men and women in this age group. So there's something going on with older people in the labour market during the COVID pandemic as well. And so now I've just showed you averages for when people leave the labour market, but we know we're in an unequal society, that there are inequalities in employment at older ages, especially by health. So in a previous study looking at the 1946 birth cohort, we showed that there were 25% of men and 20% of women retired for negative reasons before the state pension age. A large percentage of these negative reasons were cohort members' own health and their partner's health. And we also saw in a different paper that context matters, that the local unemployment rates or changing levels of these local unemployment rates definitely influences whether people can stay in work at these ages. And specifically what we're interested in with this project is about geographic inequalities. So the figure here is showing the proportion of women aged 50 to 59 in paid work. This is some of Nicola's work by 2011 local authorities. So you can see in the dark blue local authorities, more than 80% of women in this age group were in paid work, as opposed to the light blue, which is showing less than 60% of women in this age group in paid work. And you can see that there's a lot more dark blue areas in the south of England versus the north of England. So we're talking about this inequality in geography, this north-south divide. And if you look at a map of health of the population, so life expectancy for females at age 65 by local authority, it maps on this kind of paid work pattern, maps on to population health at older ages as well. So the light purple areas have the highest life expectancy, the dark purple, the lowest life expectancy. And so you see that the proportion of women in paid work mirrors the life expectancy values for health as well. And that's what this project is essentially exploring, this correlation. Kind of sum it up a little bit better here. So in summary, state pension ages are rising, but lots of people exit before the state pension age, a lot for health reasons. There are ecological correlations between health of older people in places and later life work exit, but there is a lot that we still don't know about this correlation and how it works. So I know that was a bit of a long introduction, but I think it really helps to understand what's going on in our data. So the objectives of our project specifically are to identify what concepts and metrics of health are appropriate in trying to measure the health of an older population in a given place, particularly around work exit. And we did this in two different ways. The first was a scoping review to explore which concepts and metrics of health are appropriate to measure the health of older population, or at least that's what we set out to do. And the second bit is a quantitative analysis, so specifically trying to get at how do these associations between health in a place and work exit, how do these work? And so I'm going to show the first bit of the scoping review. So like I said, we had this aim to look at which concepts and metrics of health are appropriate to measure the health of an older population. The output for this ended up being was what health indicators are available at a population level for subnational geographies. Essentially, giving a sneak preview, there was hardly any published work specifically on just the health of older people in a place for these small geographies. So couldn't do a scoping review on that, but I think it does give us a lot of valuable information to look at health indicators for the entire population. And then we had a little bit on what was available for just older workers. And we had this kind of two-stage strategy for doing the scoping review. The first step was to conduct a title abstract search on these three different concepts, one being health indicator, so obviously which health indicator, and then public health and population assessment. And this became apparent in the search that we had to do it this way, because if you just put public health, you might just get health in a hospital or in a very local area. You won't get an assessment on a population level. So we had to put all three in. And then it became very hard to identify whether this was talking about geography, whether they had geography data in an abstract. So we had to do that second as a full review assessment. Sure. And then we ended up doing this scoping review in four different data sources, essentially. So we had Ovid Medline and Scopus for academic literature. We had Google Scholar for more grey literature, like things like reports from WHO. And we looked at the statistical agency and public health websites of all of the different OECD countries, which became really valuable in being able to do, I think, a very comprehensive assessment. And there was a lot more there than there was in the academic literature. And through this, we ended up with about 60 publications and 74 websites as well. And just to give you a quick overview of the kind of data that we extracted, here we're showing, the country that the data came from, the health indicator data source, the years that the data was available, the specific health indicators. So here we have all-cause mortality, cause-specific mortality, etc. And then the geographic data that was available for. So this is just for the mortality indicators. This is just a quick view. But I'm sure what you'd really like to know about is the results. So the first main outcome was that across the 38 OECD countries, there were actually only 12 overall health indicators available at a population level for subnational geographies. And I'm going to list them here. I'm not going to read them all out separately. But the reason for why I would say there's so few indicators is actually a good thing. And that there's been a lot of work by the WHO and the EU to harmonize these health indicators over for public health reporting. So in essence, the reason that you could say, well, there's only 12, but actually I think it's good because there's been a lot of this harmonization as well. What came out that was really interesting to us was that the second result, that these health indicators varied by data source. So specifically the mortality and the morbidity indicators were generally from different sources. The mortality indicators from government statistical or public health institutes, and the morbidity indicators more from surveys, censuses, and individual studies, which was interesting. But I think the overall, maybe the big result from this paper is talking about the health indicators by geography. So this figure is showing the frequency of overall health indicators available in OECD countries by this geography. I think the way to read this is that, for example, if you are in any of the 38 OECD countries, you would have all-cause mortality, so that the kind of darker green color all the way to the left, at the regional levels of TL1 and TL2. For any of the other health indicators, except life expectancy at 65, you could get data at we call a NUTS2 regional level for 26 EU countries. So that's the light blue. So, all of a sudden you're going from 38 countries to 26 for that. If you talk about a medium geography, so like municipality, which is the orange, kind of similar to local authority, this was limited mostly to European countries and varied a lot by which health indicator you used. And then anything smaller than that varied considerably by geographic definition, and you really couldn't do a cross-country comparison at anything smaller than local authority, essentially. And if you would like to read more about this work, it was published this January, so very exciting. And I'm also very happy to email it to you. So that was the first part of the project was the scoping review. Now we've gotten into the second part, which is the quantitative analysis. So now we're trying to look at the specific associations between health in a place indicators of older people and these work exit social economic outcomes. And we have 4 different research questions within that quantitative analysis, one of which I'm going to show today, number 2, which is looking at, are there differences in associations by which health indicator you use? And then we're also working on whether there are differences by geographic scale, trying to get into causality. So if you change these place level health indicators, do you see changes in work exit outcomes? And are these relationships consistent across places? So how well does our kind of data fit? And we've been using the ONS longitudinal study. And if you're not familiar with this, this is based on the English and Welsh censuses. It started with the 1971 census, and the individuals are followed up in the subsequent censuses. And it's a random selection based on 4 birthdays, essentially a 1% sample of the population. And this is really good for our study because it's a random sample across geography, so we can get really nice representative geographic data and also be nationally representative of England and Wales. And the way that we have gone about the study, so we're just using the 2001 and the 2011 censuses. And what we've done is we've linked in these health in a place data from census data, ONS vital records for everyone in those places to the ONS longitudinal survey, where we have the data on the social and economic outcomes. Just for today, I'm going to show you the cross-sectional 2011 data results. And we actually have 2 samples that we looked at. One, the entire adult population from age 16 to 74, and an older persons in places data set. And the reason that we didn't just restrict to older people themselves is because we wanted to know, is this health in a place effect? Is it just, is the health of older people in a place only affecting the older people in that place, or is it affecting everyone? Which I think is a really nice policy question. And the economic and social outcomes we used that we're looking at, there's 6 different ones. Work status, so in paid work or not. Work hours, so part-time, full-time. Economically active, which I'll show in a minute. And then these other occupational groupings, so NSEC, social classifications, caring, and age stopped working. But just for today, I'm going to show the first 3 because they go together. And the health in a place indicators that we are looking at, so we're looking at older people in the 2011 census vital records, and we defined that as aged 50 to 74 with some sensitivity analysis for kind of different age groups within that. And we essentially have 9 different health in a place indicators. You can read them here. I won't go through them. I'm happy to provide more detailed information if you're interested on how we actually define these. But these are essentially trying to measure, in those local areas, this is the health of the older population. And we put in a few kind of test variables. So obviously life expectancy at 50 at birth, and infant mortality rate does not measure the health of older people, but we've done that on purpose to test whether this is just an effect of health of older people or it's just a general health effect as well. Right. And the analysis that we've done is some generalized structural equation modeling with random intercept to local authority. That's just because this is area level data. And we used it to assess associations between these 9 health in a place indicators and the odds of self-identifying as one of the work categories. And then it's done some adjustments for individual self-rated health. And we've tested for whether these associations vary by gender and age category, because there's definite gender differences in employment outcomes, and obviously the age category ones. So are these effects stronger in the older age groups or versus younger? And we've also produced some predicted probabilities of work categories with margins, which I'll show in a minute. And so just to give you an idea of the distribution of these place level health indicators, which I was actually quite shocked by. For example, this slide is showing the proportion of people in a local authority. So there's 348 local authorities in 2011 in England and Wales. And let's say if you're using self-rated health as the indicator, the unhealthiest local authorities, we say almost half of older people in those local authorities are saying their health is bad versus good, versus the kind of say healthiest local authorities where less than 20% of older people said their health was bad. So there's actually quite a large distribution across local authorities in older people's health. And for the purposes of the analysis, I put these into groups of 3, so that the best health in green were south in red. So, and if we get into the main results, so this figure is showing the age-adjusted odds of not being in paid work versus in paid work by the local authority health indicator tertile for the entire adult population. And we've got the medium versus the healthiest tertiles on the left in the yellow, and the unhealthiest versus healthiest in the red. So for example, the far left bar is saying there's a 20% higher odds of not being in paid work for the middle versus healthiest tertiles of bad self-rated health. And then you have long-term illness, age-specific mortality rate, avoidable mortality, et cetera, et cetera. And I think my general interpretation of this figure is that for any of the health in a place indicators were associated with not being in paid work, but that there were some slightly stronger associations for the self-reported health indicators, so the self-rated health and the long-term illness, which I think is interesting. I had kind of expected it might be healthy life expectancy or disease-free life expectancy, but it seems to be more about how people in their area rate their own health. And I know the next question that people are going to ask me is what happens if you adjust for individual self-rated health, and that's what you see here. So the associations are reduced a bit when you adjust for individual self-rated health, but they do not disappear. So. And then if we apply these margins to the analysis, so now we're saying, I'm not showing the associations, I'm saying give me the probability of not being in paid work for men and women separately for the different tertiles of healthiest local authority. So if you look at this, you can say that for women in the healthiest local authorities, their probability of not being in paid work is about 36%, versus the women who lived in the unhealthiest tertiles, their probability of not being in paid work is more like 43%. And you see that the odds of men not being in paid work is lower than women, but the gradient is still the same. And so I think there's about an 8% difference for both men and women in the probability of not being in paid work by this health in a place exposure. Let that sink in. And if we switch this to the outcome to economic inactivity, so this is the same exact models as we were looking at before, but now the model is economic inactivity. You see that the probability of people in the cohort being in the different economic inactivities varies. So you have unemployment, you have retired, sick, disabled, or other, which includes kind of homemaker, student, and various categories. And then the probability varies by gender. So you have women in light blue and men in the dark blue. But I thought what was surprising is that that gradient across health of older people is apparent for all of these economic inactivities, and it's quite consistent across all of these other categories. So it's not just that people are more likely to be out of paid work for one category, it's applied to all of the different economic inactivity categories as well. And the remaining outcome is looking at work time. And this one was interesting because if you just look at the odds of not being in paid work versus full-time work, it's similar to the other economic inactivities, that's the same. But there were some gender differences for the probability of being in full-time work and part-time work across that gradient of health in a place. And here we're looking at long-term illness as the health measure because this was the strongest. You see that the gradient, so the probability of being in full-time work for men, so the dark blue, the gradient is quite strong for men, but it's much weaker for women. But the opposite is for part-time work. So the gradient by health in a place for women is quite strong for part-time work, but it's much weaker for men as well. So you're seeing this difference by full-time, part-time work gradients for different genders, which I don't know the reason for this, but I think that is quite interesting. You know, given the differences, you know, women are much more likely to be in part-time work and men in full-time work at these ages. But why that gradient would differ, I don't know. Leave that here. And just to give a sneak preview to this group, we took the same exact cross-section, because I was showing you the cross-sectional data for 2011. And I went back and repeated the same exact analysis for the 2001 sample, thinking, you know, there's a 10-year difference between these data, but the gradients that we saw were exactly the same. And that is what I'm showing here. So the bars to the left is the 2001, and then to the 2011 data right next to that, which was pretty surprising to me. And that obviously over a decade, these gradients, these associations are exactly the same. Right. And so to summarize a bit, the key messages from the research, going back to the scoping review, the ability to measure health in a place varies considerably by country, particularly at smaller geographies. I will say that in comparison to a lot of the OECD countries, the UK does really well. Point two is that at a place level, health and work outcomes are linked in our data. And I think this is something that, this work was funded before the COVID pandemic hit, and really what has come out of the pandemic really is this as well. So saying that the health of the population and our work outcomes are linked, and this supports that. This work supports that. That the strengths of association between place level health and work outcomes will depend on the health measure that is used, but not too much. So I think whichever health indicator you use will probably give you the same answer, but some will give you a stronger correlation than others. And that number 4, strategies to improve economic inactivity may be most effective if targeted towards local areas with high levels of people in poor health. And I think just wanted to point out one other thing that has come up recently, because I know the data that we're looking at is 2011, and kind of applying it to what is happening now. So this figure is showing the increase in economic inactivity compared with the previous 3-month periods for older workers. And essentially, there's been a really sharp uptick in economic inactivity in these older worker age groups since the pandemic started. And that the Center for Aging Better was pointing out in a report recently that this means about 200,000 fewer 50 to 64-year-olds are in employment now compared to pre-pandemic levels. And we're talking about economic inactivity. So these aren't people that are looking for work. This is not unemployment. So I think this is quite a worrying trend. So we could say that the results that we are seeing, the associations that we saw, have probably gotten worse than better. And thinking about current policy relevance for the work, I think the Leveling Up government white paper should have been released this week, but we'll see what happens with that. The government has had a fuller working lives agenda over the past 5-10 years or more, trying to find ways to help people stay in work and to have fuller working lives. And also that there's a state pension age review coming up again. And so I think all of the work coming out of this project is very relevant for all of those policies. And just to give a quick summary of what we have done. So I showed you the scoping review. We have the quantitative analysis that I showed the first bit of, and working on the different other research questions as well. And coming up, we will hopefully have some focus groups soon, showing our results to some older people themselves and some policymakers to see what their thoughts about our work. And we also have some policy briefings and an event to plan as well. And I'm going to put this slide up because Celsius makes me do that. And and just to say, yeah, so that's the end of the presentation. And I'm happy to take any questions. Thank you. And I have to say how weird it is to give a presentation without an audience. Yeah.
Thanks so much, Emily. That was great. Really interesting research going on there. I would say that because I'm involved, but no, it's super interesting. It was a really, really good talk with lots of fantastic graphics as well. I'm going to open the Q&A. I want to thank also Linda Infat and Ji-Cheng Luo, who have helped organise the seminar series, and Raheel and Patrick from ISD, who are hosting it for us. It's an unusual setup in that Emily, myself and Linda cannot see the audience. So can you please put any questions you have for Emily in the live Q&A, which is a box, a bit like a chat box, but not a chat box, where you can post questions. I posted one in there earlier, which says, please put questions in the Q&A. So if you can pop your questions in there, we will respond to them. Thanks. While people are thinking of questions, I'm going to tell you what's coming up in the seminar series. These are hopefully in person in the spring, dates to be confirmed. We will have Dr. Massimo Stifoghi from Epidemiology in Lazio, Professor Robert Hyatt from the University of Southern California, and our own Dr. Rebecca Lacey. We've got coming up subject to room bookings and travel plans of the people coming from outside the UK. We haven't had a question yet, so I'm going to ask a question, Emily. In the meantime, if you had 30 seconds in a lift with a government minister, what would you say to them about your research?
That is a very good question.
You can tell we haven't prepared this.
No, I think if there was one thing to put in the levelling up health paper, I think there should be quite a huge focus on health, which I haven't seen previously discussed very much at all. And that specifically, if we want to allow people to participate in the economy, they need to be in good health to be able to do that, for all sorts of reasons. And, this project specifically showing, for older people, if we want to make sure they can make it to state pension ages in employment, we need to make sure they're in good health.
Oh, I've published a question, but now I need to... Linda, can you see that one I've published?
So if people are still watching, I'd say this is something that we are now struggling with on the project, is turning these academic results into policymaker relevant outputs and having these, and we do have an advisory committee with different organizations, and the Health Foundation has been really good as well. They also have an advisory committee for the program. But it's quite challenging. Yes, I did see the question. So are we able to look at other area level outcomes like area deprivation? Yes. So I've also looked at the results I showed adjusting for area deprivation, and it's the same story where it reduces them a bit, but the results are still apparent. It's just deciding what to show. There's just so much to show.
I think I'll pick up on the other question and read it for you, Emily, because of Linda's audio. So again, thanks, Emily, great presentation. What, if any, adjustment to statutory state pension do you think your results support?
I mean, I think there's two issues. One is the impact of the COVID pandemic on life expectancy. So should we be, this is just my policy thing, should we be increasing state pension ages when life expectancy might not essentially be going up as we had predicted? But I think what this work is really saying is there's such huge inequalities in who can stay in work, particularly around health reasons. And so basing this kind of state pension age rise based on average life expectancy to me doesn't seem appropriate, because you have such large inequalities in the health of the population, across social factors, but also across geography. So essentially you have a lot of people living in more like the north of England, etc., who are going to leave work at an earlier age, before the state pension age, and a lot of people in the south of England being able to stay on because they're in good health. So I think the policy should take account of the fact that we live in an unequal society and not be based on averages. So
yeah, I'll probably follow up with the fact that the ILC UK are involved in the research as well, and Emily and I joined a online discussion about this the other day, and the state pension age review team are taking details of various projects, including ours, to feed into that, which is great news.
And I think in the last state pension age review, they'd recommended, having an option, even just a year or two before the state pension age, that people who were in poor health could have this option of retiring, getting their pension early. I mean, I guess that would mean they might get less per time, but then at least they would have the option. Because I guess the option is really, you're in poor health, you can't work any longer, you go on disability, which is a smaller payment than the state pension age. So it's kind of like you've got this more people in the north of England who are having to leave work at earlier ages, going on potentially benefits to wait until they can actually get to a state pension age, which is being increased. So, yeah.
Another question here from Brian Beach. Did you look at the differences in economic activity levels restricted to those aged 50 to 64 or 50 to 59 to see, for example, how the retired category changes?
I'm going to have to think about that question. So you're saying in the outcome, is that the question?
So it's the economic activity levels restricted to those aged 50 to 64 or 50 to 59.
No, we looked at it. We just looked at the age for the older workers themselves versus the younger adult population. But we could look at that looking at within the older groups, whether there's differences there. I think basically what you see is that the effects are slightly stronger for the older workers than the younger workers, but it's apparent in both. So I would expect to see that maybe there are a tiny bit stronger associations in the working age population than the older ones, but that would be my guess. But good idea.
And then I think a follow-up question from Esme Eldon. Thank you, so interesting. We'll look up Paul. Thanks for outlining. I see it's hard and probably better to look at it over decades. Interesting that the attempts at levelling up seem not to do much for health, and the entrenchment remains, seemingly beginning even in the 1840s agricultural south and industrial north. Thank you for your time.
Yeah. Yeah, no, I think we were quite surprised, maybe a bit, not surprised, but maybe disheartened that these inequalities are so long-standing. And I think a lot of the policy conversations happening now seems to think like this is a new thing, but I think it's a very, very long-standing inequality that needs to be addressed with maybe some big thinking rather than just tinkering around. I'm trying to look at all the questions.
Yeah, I think they're all published now, even though it's telling me that there's a new one. This is our first time using this software. So we have to publish the questions. In case you ask a question, that's somehow inappropriate, or occasionally do what I do and lean on the keyboard and put in a whole load of random characters. So we can publish or dismiss them. And I think I've published all of them, but it's telling me there's one I haven't published, but I can't see it.
I think there's one more about whether there's a reverse causality between employment status and people's health. In your research, it seems the unhealthy people are more likely to be unemployed, yes. However, it's still possible that unemployment deteriorates individuals' health. And how would you address this? So yeah, so I think what I presented now was just cross-sectional. So there's no way to piece out the temporality there. What I'm working on now is to do a bit of that, trying to do some longitudinal analysis. So we're going to use both the 2001 and the 2011 censuses and try to look at, if you see changes in this health of the population, do you then see changes in the economic variables? So yeah, so trying to get around some of that causality questions. But this grant was quite interesting because the Health Foundation themselves, what they're really interested in is the measurement. So a lot of this project is around measurement of the measures and stuff like that. We're not interested in causality yet, I think. So we had to tone down the proposal to be more about measurement rather than causality. But as an epidemiologist, I want to know about causality. So, yeah. So thank you for your question.
I think that may be everything. If anybody got any more questions, please pop them in the chat. Thank you again, Emily. That was a really great start to our seminar series. If anyone on the call would like to present a seminar, either online or in person, please get in touch with myself, Linda, and Ji Cheng, and we'll arrange a date for that to happen.
Yeah, and thanks for inviting me to present. Thank you.
Thank you.